So, thank you for the invitation and the introduction. I was asked to speak about deformity analysis, particularly in HTO, as this remains the workhorse in osteotomy surgery. And so I guess just jump directly into the topic. So, obviously, when you do osteotomies, you need an X-ray that you plan upon, but beware, it might be somewhat in the wrong orientation. So that's the first pitfall you might run into. Whenever you make your X-rays, make sure that the patella points forward and orientation or rotation profile is hit correctly. Also, the condyles should look straight at you and not curved like in this example, and the head of the fibula in the proximal tib fib should be covered by 1/3. Otherwise, you get, as you see here, just by the rotation, completely different that you cannot plan upon. So once again, the condyles should look straight at you. The patella, which is obviously quite mobile, should somewhat be in the front, and 1/3 of the fibula head should be covered. That's an AP long leg X-ray. So now let's jump directly to Johann Mikulicz. 150 years ago, he taught us something about deformity analysis already, and he taught us that not only the Mikulicz line, which is the mechanical leg axis, is somewhat close to the geometrical middle, a little bit medial of the knee. He also taught us that the joint line orientation is 3 degrees inclined to the medial side. And, well, there is a purpose for that. And the purpose is that in normal stents, bipedal stents, when there is almost no weight or just 50% of your body weight on each foot, then actually it doesn't play a role how the joint line is oriented. But when you divide the joint line by these MLDFA and MPTA angles that I will come upon later on, then you see that when you run, jump, hike under dynamic conditions, you medialize your foot, and whilst medializing your foot, you all of a sudden horizontalize your joint line in order to gain balance and put your body in the center of mass. So let's look what KKley made out of it, because he defined the nomenclature for what we want to make our analysis on. And he defined first attend joint centers. Well, the center of the proximal femur is the center of a circle, and that is probably quite easy to find. Not so easy if you look at the knee. You can use bony or soft tissue landmarks. Anyhow, these blue dots are very close to each other, and it doesn't really play a big role what kind of landmark you use. You just need to have a standardized procedure. And the same applies for the ankle joint, whereas I personally always take the center of the talus. Now, beside these joint centers, there is also joint lines, and that's first the joint line of the femur, which is the connection of the condyles, and the one of the tibia, which is the connection of the subchondral sclerosis. And now, the next thing that we need to look after is axis, anatomic and mechanical axis, but for osteotomy we rather apply for mechanical axis. So the anatomical axis is somewhat the definition of the shaft. But we're not looking at the shaft. It might work for the tibia, as at the tibial side, the mechanical and anatomical axis are somewhat parallel. But at the femoral side, due to the femoral neck, there is a difference, and you always need to think about that. We plan on mechanical axis, which is connection then from the center, the joint centers, that is way more important than the anatomical axis. So the mechanical leg axis itself is the Mikulicz line. The Mikulicz line is passing through the knee somewhat a little bit medial to the geometrical middle, as we said already. And it just gives you an overall idea whether you find a varus or valgus malalignment. And now let's come to the nomenclature, because KKley defined now the nomenclature for it, and that's very important so that we speak about the same thing. And you can either have a mechanical anatomical axis, and I said already we look at mechanical, at the tibia it doesn't play a role as it's parallel. And then you have medial or lateral, proximal or distal, and femur or tibia. And that brings us to the MLDFA, the mechanical lateral distal femur ankle, and the MPTA, the medial proximal tibia ankle. And due to the inclined joint line of 3 degrees, they are both almost 87. Quite easy to remember then, and you always need to differentiate whether you plan or whether you we plan on mechanical axis anyhow, but you need to decide and individualize your planning and your analysis, because if you don't know if the malalignment is in the femur or in the tibia or maybe in both, then you don't know where to carry out your osteotomy. And it might be in all of them or in none of them, even as the joint line convergence angle, and therefore the joint itself might also be the problem. So make a proper analysis, other you cannot find out. Now let's do such a planning and draw your Mikulicz line, and that gives you the overall idea. Okay, I have a varus. I want to bring that to slight valgus, so you draw a virtual Mikulicz line where you want to intersect. You define a hinge point, and that hinge point is now important because I want you to become actually the hinge right now and change your position. So that makes it way easier to understand what happens now and how to change, because now the hinge itself becomes the center of everything, and around the hinge everything changes and rotates. So you want to rotate your actual ankle joint position to your virtual one. When you do this, you basically draw this line A and you rotate it to line B, and that describes an angle, and that angle has to be transposed to the medial side, to the cortex, in order to win a wedge base height, and on a calibrated X that now can be used in order to determine your surgery. So when you look at traditional studies like this very famous from Fujisawa, who somewhat hypothesized a virtual Mikulicz intersection point of 30 to 40% of the lateral compartment, which is 65 to 70% tibial plateau width. Well, he somewhat changed Mikulicz line, as you see here, but he somewhat disrespected the rotation. And when you look at these latest studies from Shao and Babis from the Mayo Clinic, who basically had a software based on a rigid bone spring model that kind of tailored their osteotomies, they found way better results when respecting the joint line orientation. So you can change this 11-degree varus with 100% medial loading to an unload of the medial side, 40% medial loading, but a 9-degree lateral tilt, see in the middle, by a single level osteotomy. Or you can perform a double level osteotomy and bring it to the same unloading, but just with a 2.5 degree lateral. And that is absolutely favorable, as results of such a surgery are way better, and not all these deformities, and that's what we've learned here, can be addressed at the tibia. Even if it's a varus, you need to make a proper analysis of the malalignment in order to find out where the malalignment is, and there you have to treat. And you never ever must expect these MPTAs of 100 degrees post-operative. That simply doesn't work. There's nonsense. It's completely non-anatomic, and it's way worse than what the patient came with. So if you find something like that, back to your drawing board and rather perform a double level osteotomy, for example. So the take-home message is appropriate X-rays are mandatory. Plan every case, analyze individually and not overall, because other you cannot find where your malalignment is. Treat the malaligned bone, and if necessary both. The joint line is inclined by 3 degrees to the medial side and is probably way more important than thought till now, maybe as important as the correction of the Mikulicz line. So keep straightening limbs. Thanks a lot, and safe distance, please. Thanks.